Good morning. Welcome to day 2 of the public meeting of the Physician-Focused Payment Model Technical Advisory Committee, known as PTAC. My name is Dr. Lee Mills, and I'm one of the PTAC co-chairs, along with Dr. Chini Puluru. Yesterday, we had a number of experts share their perspectives on improving multi-payer alignment in value-based care. Today, we have a great lineup of experts for our last session that will focus on addressing challenges to advance multi-payer alignment. The committee has made considerable effort to include a variety of perspectives throughout this 2-day public meeting. Later this morning, we'll have a public comment period and welcome participants to share a comment related to the meeting's topic. As a reminder, public comments will be limited to 3 minutes each. If you have not registered to give an oral public comment but would like to, please email ptacregistration@norc.org prior to the public comment period at 10:50 Eastern Time. Again, that's ptacregistration@norc.org. Then the committee will discuss our comments and recommendations that will inform the report to the Secretary of HHS. Because we have some new folks online who weren't able to join yesterday, I'd like the committee members to please introduce themselves, share your name, your organization, and if you'd like, tell us about your experience with our topics, and I'll cue each of you in turn. I'll start. I'm Dr. Lee Mills. I'm a family physician. I have the pleasure to serve as Chief Medical Officer of Aetna Better Health of Oklahoma, one of the state's 3 managed Medicaid plans. Over my career, I've had the pleasure of practicing and leading 5 or 6 different CMMI models over the years from both a health system provider and a payer perspective. Next, let's go to Henish.
Morning, I'm Henish Bansali. I'm an internal medicine doctor, primary care practicing by training. I was most recently Chief Medical Officer for Medical Home Network, an enablement entity that worked with federally qualified health centers across 8 states. Prior to that, I was at Dooley, or DuPage Medical Group, as the Senior VP from Medicare Advantage. Dooley oversees 1.2 million patients in a multidisciplinary fashion. Prior to that, I was at Oak Street and have spent most of my career on value-based care.
Lindsay?
Thanks, Lee. Good morning. I'm Lindsay Botsford. I'm a family physician in Houston, Texas, where I care for patients of all ages, including Medicare beneficiaries as a PCP. I'm also the regional medical director for the Midwest and Texas with Amazon One Medical. I've got the pleasure of caring for patients and leading in various ACOs and value-based payment models for the last 15 years, including the ACO REACH model, where I currently serve as the chair of the governing body of the Iora Health Network, formerly led by one of today's presenters, which most recently got $37 million in savings for the 2023 performance year. I'll pass it back to you, Lee.
Wonderful. Lauren?
Good morning, I'm Lauren Harden, Chief Integration Officer for HC2 Strategies and a nurse by training. Our firm is really focused on building cross-sector approaches in multi-payer models, combining and supporting public health, healthcare, community-based organizations and states, and coming together to serve complex populations. My background includes many years in serving and designing care management approaches for complex populations, including in many value-based care models, leading a complex care center model that was recognized by the National Academy of Medicine as well as the American Academy of Nursing. I was part of the team that initiated the National Center for Complex Health and Social Needs out of the Camden Coalition and partnered with many people across the country designing models for complex populations.
Thank you, Lauren. Let's go to Larry.
Good morning. I'm Larry Kaczynski. I'm a retired gastroenterologist. I had a rich career of 35 years. Helping to build the largest GI group in Illinois, the Illinois Gastroenterology Group, which submitted one of the very first PTAC proposals called Project Sonar, a value-based care solution for GI conditions. It was recommended for testing by PTAC. Since then, that project has become a company, Sonar MD, a VC-funded company that's now in multiple states across the country with the same program. I'm also a fractional CMO for a very interesting AI-powered microbiome company called Jonah. And my most recent initiative is a company called Viovac, built around olfactory device, an enos that can help people decide on a healthy diet. I've been on the committee for 5 years. I'm looking forward to today's meeting.
Thank you, Larry. Josh?
Good morning, everyone. Josh Sloan, internal medicine physician. I spent many years thinking about the topic that we'll talk about today, physician-focused payment models, across different payers, and how to drive kind of population health and value-based care, both from a clinical practice perspective, but also a leadership perspective, holding a number of roles over preceding years. I also led a portfolio of research on these topics, looking at things like episode-based payment models, accountable care, and population-based payment model as well. Currently, I continue that work. I also kind of have oversight of enterprise programs at Ascension using technology and capabilities within models to address populations like those insured through Medicare and others. Excited for today's conversation.
All right, Walter.
Good morning, everyone. I'm Walter Lynn, internist based in St. Louis, founder of Generation Clinical Partners. We are a medical practice dedicated to helping senior living organizations transition successfully into the world of value-based care. I'm also the Chief Clinical Strategy Officer for LTC-ACO, and our practice has direct experience with other value-based programs, including bundled payments, PACE, and home-based medical care.
Thank you, Walter. Krishna?
Thanks, Lee. I'm Krishna Ramachandran, Chief Information Officer, United Healthcare. 24 years in healthcare in the payer, provider, and healthcare technology domains. Most of it actually furthering value-based care, including efforts on multi-payer alignment. So a topic close to my heart. Thank you.
Thank you. And David?
Yeah, good morning. David Tyson. I'm the Senior Director of Public Policy at Novant Health, which is a integrated delivery network that spans the Carolinas, 25 hospitals, over 900 locations. I've been with Novant about 10 years, and that entire time I've focused on all things public policy, but mostly around navigating value-based payment models, helped the system sort of understand and move forward in the early days of MIPS and MACRA and the Medicare Shared Savings Program, and have sort of expanded outward from there in focus and reach. So we currently have about 650,000 patients under value-based arrangements across all payers. So looking forward to the conversation today.
All right. Thank you, David. For today's agenda, we're going to explore a range of topics on improving multi-payer alignment in value-based care. The background materials for this public meeting, including an environmental scan, will be posted online at the ASPE PTAC website meeting page and the public meeting registration site. Discussion materials, public comments from this meeting will inform our report to the Secretary of HHS on improving multi-payer alignment in value-based care. I'd like to note, as always, that the committee is ready to receive proposals on possible innovative approaches and solutions related to care delivery, payment, or other policy issues from the public on a rolling basis. We offer 2 possible submission tracks for presenters, offering flexibility depending on the level of detail about payment methodology. And you can find that information about submitting a proposal on the ASPE PTAC website. Lastly, on behalf of PTAC, I'm pleased to share the committee is now producing a series of issue briefs that summarize the latest information and evidence related to value-based care that the committee has explored in its public meetings over prior years. Currently, 6 issue briefs, along with highlights from PTAC's 2020 through 2025 theme-based public meetings, are posted on the ASPE PTAC website. The committee will be publishing new issue briefs on additional topics into the very near future. And now I'm excited for this morning's conversation. I'm going to hand the baton over to Lindsay to welcome and facilitate our first session. Lindsay?
All right, thank you, Lee. Good morning, I'm Lindsay Botsford, one of the PTAC members that has the pleasure of facilitating this session. So we have with us 4 experts to discuss their perspectives on addressing challenges to advance multi-payer alignment. You can find their full biographies and slides posted on the ASPE PTAC website and the public meeting registration site. So at this time, I'll ask our session participants to go ahead and turn on your video if you haven't done so already. After all experts have presented, the committee will have plenty of time to ask questions and engage in what we hope will be a robust discussion. So presenting first, we're pleased to welcome Dr. Ben Kornitzer, who is a Senior Vice President and Chief Medical Officer at Aetna, a CVS health company. Ben, welcome.
Great. Thank you so much for having me, and glad that I'm out of the blizzard on the East Coast that Rushika is dealing with, but I'll be joining you in a few days. Also just want to acknowledge, what a nice reunion this is, seeing so many friends and colleagues from the past couple of years on this as well. So for background, I'm a primary care physician. My own practice focused on care for homebound older adults. Started participating in ACO models really quite early on with one of the early community-based ACOs. Spent a number of years as a chief medical officer for Mount Sinai's network in New York, including putting together its clinically integrated network. And so significant time thinking through those models as well. After that, spent a number of years at Agilon, so a senior-focused value-based care enablement organization with largely independent primary care and multi-specialty practices going at risk with different payers around the country. And I'm now the chief medical officer for Aetna, dealing with all lines of business, including our Medicare, commercial, and Medicaid populations. If we can go to the next page. So we've already seen my bio, so we can move on. So if we talk about, where we are in terms of healthcare in 2026, I think that, this is a slide that should certainly resonate with everyone. But healthcare is not delivering the quality of care that patients expect, that our country deserves. The costs of care are skyrocketing. Trend year over year is, largely unmanageable, and patient out-of-pocket costs are really preventing them from getting the high quality care that they want. And so some data that we wanted to show here, 40% of consumers, report that they are, delaying care due to that cost of care. And we actually know, and one of the formal precepts of what really good value-based care looks like is it should be longitudinal care and it should be continuous. And so when people delay that care, that means that their renal disease is worsening. That means that they're at higher risk of having, critical diagnoses, whether they're oncologic or neurologic diseases that could have been prevented. They will miss those opportunities to really intervene. We also know that from a provider angle, care isn't working at all. So, 88% of physicians report that they want more time to spend with complex patients, but they're unable to do so. We have phrases in medicine where people measure things like pajama time, right? So the fact that providers are discussing how they're spending their time after hours doing paperwork, not necessarily actually involved in the quality of care and the outcomes, is a major issue. And I think it also shows up in the challenges that we have in terms of access to really high quality care. And so part of the solution that we need to think through is how do we create that access for those patients, particularly those in most need. And then finally, from the employer lens, so, we deal with a large number of commercial plan sponsors, and I can tell you at every single one of those conversations, there's two things that they bring up. One is ensuring that they get the highest quality of care for their employees, but two, what can they possibly do to really improve the trend, which is unmanageable and to a large extent almost unpredictable. And so these are really major drivers of where we are in healthcare in 2026. If we go to the next page. So what's different between fee-for-service and value-based care, as we see it through the lens of Aetna, right? So, right now, fee-for-service, largely volume-driven. Large number of the costs are really associated with that waste and overutilization, which isn't showing any member benefit whatsoever. But at the same time, we realize that there isn't the quality and value that we want. So I'll talk a little bit later about how we're making sure that, the relationships that we have really drive those quality and value outcomes, including how we think about our networks and who's participating in those networks. In a fee-for-service model, it's really reactive and episodic. And I think there have been a number of great studies actually showing that, particularly within primary care, it's not just the number of touch points that high-risk members have with their primary care provider, but are those being done proactively? And we actually see that downstream utilization is much more manageable when providers have a mentality that they have an ongoing relationship with a member, and it's their responsibility to think through almost for that entire year, what are the appropriate screening tests, what are the check-ins that they need to have, what are the conversations, whether they're goals of care or other that are really important, and doing so not in a reactive way, but in a proactive way. That relationship, I think, is absolutely critical. I think two of the biggest gaps that we have right now in healthcare that really creating the right dynamic between payers on a multi-payer model and value-based care for those members is building both trust and long-term relationships. And so I think anything that we do that's going to address better outcomes for members really needs to emphasize that longitudinal nature of that relationship and create that bi-directional trust. And that's what you finally see come to play in the relationship between providers and health plans. And so, when it's a fee-for-service model, it's transactional, it's service-driven, it really becomes a zero-sum game. And when we think about what good value-based care looks like, it's a partnership, right? Value-based care is a team sport. And so it's thinking through how do we actually set up providers to do well in these models? How can we share the right sorts of data, the right insights to set them up so that they can continue on and sustain their practices and really get the best outcomes for the patients they're taking care of. Then if we go to the next page. So, historically, there have been some real challenges to adopting value-based care models. So as a primary care doctor, the models are fragmented. So when I would have a backpack and go around New York City, I didn't think, well, this is a Medicaid patient, this is a commercial patient, this was a Medicare patient. I thought of my patients as my patients. And so the more that we can reduce that fragmentation, create a seamless experience for providers, I think is absolutely critical. The operational complexity and burden, particularly for smaller practices. And so how do we create solutions that are accessible, actionable? How can we share data that can be easily used by different types of providers so that they're really successful? Create new ways of having data interoperability. We think that that's absolutely critical, that data needs to be bi-directional, that everyone should be participating, whether it's through the HIEs, whether it's through aligned ACO networks. I think that's absolutely critical. You need a certain amount of financial stability to be able to really invest in long-term primary care. And so making sure that those incentives are meaningful enough and that providers have the economic wherewithal to really go and participate more meaningfully in value-based care is absolutely essential. And then finally, you need a large population of providers really rallying together. As I mentioned before, value-based care is a team sport. And so one of the things that we see is valuable, for example, coming from the Aetna lens, is because we participate in essentially all lines of business, commercial, Medicare, Medicaid, we can deal holistically with providers and helping them think through, how can they create, really successful models of care rather than just thinking through the silos of those individual programs. And then finally, I'll just share a little bit about some of the work that we're doing at Aetna. If we can go to the next page. So we really want to transform the relationship that we have with providers from a transactional one to one where it's a real clinical collaboration. So the way we do that is, we work closely with them to make sure that they have access to timely data, that data is insightful, that they understand where there are opportunities to better manage patients, whether it's who are their high-risk members, who are people at risk of having readmissions, who are people who haven't been screened for critical conditions or where we see that they aren't taking important medications. Again, as I mentioned before, our ability to understand what it takes to succeed in that environment, make sure that our network reflects who really are those high value providers and make it as transparent as possible, I think is really important. We have teams of clinicians, care managers, performance management capabilities that we can really wrap around these relationships to make sure that value-based care providers do well. We think that the timeliness of data sharing is absolutely critical. I think it's something that, in particular, Aetna has been investing very significantly in. But we also see just across the space. So, for example, within Medicare Advantage, we know that our partners who work with us do very, very well when we are able to get them timely information. And we actually see that they improve the quality of that care quite dramatically. And then I think for everything that we do, building up the knowledge base to say that we understand that value-based care really is moving the needle and what are the particular activities that are most impactful is an investment that we all need to make together. I think this is an opportunity where all ships can rise in the harbor together. Just from our own data within Aetna, we published recently in JAMA Health Forum evidence that patients in a value-based care model had significantly better blood pressure control, hemoglobin A1C control, lower admissions, readmissions. That's consistent with data that we've seen from peer organizations around the country. And so, that gives us conviction to continue to invest in these solutions and make sure that we're giving the opportunity for providers and for our members to get access to what we think is really, exceptional high-value care. Thank you.
Thank you, Ben. So we're going to save all committee questions until the end of all presentations, so we'll be back. Next, we're glad to welcome back Dr. Vivek Garg, who's President and Chief Executive Officer at the National Committee for Quality Assurance. Vivek, please go ahead.
Hey, good morning, everyone. Great to see many of you again and to see the fellow panelists here. It's really a privilege to be here in front of the committee again. As Lindsay said, I'm now President and CEO of the National Committee for Quality Assurance, but I spent a number of years as a practicing PCP and internist, building clinical programs at new entrants like One Medical and Oscar Health. And then I've spent most of the last decade prior to the NCQA as a CMO in national value-based care groups, supporting complex care models, clinical teams across the country, and trying to move the needle every day on clinical performance and outcomes with organizations like CareMore and CenterWell. I joined the NCQA at the beginning of this year to focus on exactly issues like the committee is talking about yesterday and today. How do we align our ecosystem to produce the quality and outcomes that Americans deserve while sustaining our healthcare professional workforce and addressing the societal cost issue? For this conversation, I was asked to focus on a challenge many of you see firsthand: why multi-payer alignment is so hard to achieve in practice, especially in Medicare Advantage. Ultimately, I believe this is really a systems design issue, and a big part of the equation is the quality and outcomes architecture that we deliver through so many different programs and vantage points. For more than 35 years, the NCQA has worked to define and drive healthcare quality through accreditation, standards, performance measurement, and expert support. But what this has really been about is to help the ecosystem create clarity about what good looks like, how to measure it, and how organizations can improve over time. We're fortunate to sit in a neutral and independent position, working across stakeholders to help align expectations and accountability. If you go into the next slide. These are some statistics about the reach of our programs and frameworks like HEDIS measurement. More than 200 million people are covered by health plans that report HEDIS quality measurement. And almost above 70% of Americans are in an NCQA accredited plan. And almost 60,000 clinicians work across more than 11,000 practices that are recognized by programs such as the Patient-Centered Medical Home Program. So that means our team sees alignment challenges across plans, care delivery and programs, not in isolation, but across a very broad swath of the American population. If we go into the next slide. Here are four main issues that we see. I think they really mirror what Dr. Kornitzer just spoke through, but the first is really trust and transparency in data. If you're operating under a value-based framework with a quality focus, you sometimes don't really know who your patients are. You know them as a clinician, but you don't know them systematically. It can take months to get full attribution, to have data flow from different plan and policy stakeholder partner programs. And this really drives a lot of fragmentation and incomplete views about clinical utilization and events that are happening, the conditions that people are suffering from, and ultimately the cost drivers and intervention opportunities that we're all trying to orient around. Plans aren't always seen as neutral partners, and there's often a lot of variation in the timeliness, accurateness, and completeness of data that's received. The ultimate result of this gap is that clinicians are held accountable for outcomes that they cannot see fully in time to often influence. A second gap is really around misalignment between accountability and control. Clinicians and medical groups under risk may be accountable for costs that they cannot meaningfully influence, including out-of-network leakage, specialty care, high-cost drug utilization, transportation, and other ancillary benefits. Third, there is a lot of variability across contract terms. Even within Medicare Advantage, which benefits from the uniformity of the STARS framework, performance metrics can vary, incentives definitely vary, reporting requirements vary, and rules about what to focus on when and what level of value you can drive from them also vary significantly. And fourth, which I know the committee has talked much about already, is the multi-payer complexity. Medical groups simultaneously operate in Medicare Advantage, under Medicare fee-for-service and ACO programs, as well as Medicaid and commercial programs, each with different signals of success. Ultimately, this means that care delivery organizations face fragmented accountability signals across Medicare programs, making alignment very hard in practice. If we go into the next slide. Despite these challenges, we do see opportunities to close the gap. First, like Ben and others have talked about, is to strengthen our investment in primary care to help align delegated risk and payment models with advanced primary care capabilities and the population goals that matter the most. We all know that the US spends single digits of the healthcare dollar on primary care, and we have so much domestic and global evidence that societies that spend double digits in the mid-teen % benefit from strongly improved population health outcomes. Second is to harmonize the quality and outcome signals, even just for seniors as a starting point, to align on a core digital measure set spanning Medicare Advantage and ACO programs, covering the areas that matter: prevention, clinical outcomes, patient-reported outcomes, avoidable downstream events that no one wants to have happen to their patients, and supported by standardized data exchange expectations, leveraging national constructs like USCDI and FHIR interoperability standards. The third is to standardize peer-provider alignment under delegated risk, clarify ownership of risk, unify the data standards, as I mentioned, and make the clinical policy and guidelines more consistent. There's a market gap here where policymakers can step in to really establish the rules of the road. In short, when alignment improves, when primary care, quality and outcomes frameworks, and risk ownership are designed to work together. To give one example, if we go into the next slide. Obviously, I've spent almost a decade working in the care of seniors. And if you look at our major value-based programs in Medicare, including Medicare Advantage, we're targeting similar populations, but have very different measures of success. MA STARS emphasizes experience, function, plan operations, in addition to clinical outcomes. Under MSSP with APP+, there's a more narrow focus on clinical outcomes and utilization. And ACO REACH in the transition to LEAD so far is prioritizing outcomes and utilization with far fewer of those other types of measures. And the result is that, as we all know, medical groups and clinicians caring for the same types of seniors and populations are asked to focus on and invest against different, sometimes conflicting signals and rewards of success. It's not just the disharmony in what they focus on, it's also about where they can invest and create standardized programs and clinical management focus areas to drive outcomes. It's not that the measures are wrong, it's that taken together they create more noise instead of a coherent measure architecture, especially when it's compounded by different levels of data quality, timeliness, and different incentive frameworks. So we really need to think about the shared measurement framework and standardizing so that we can get to this more uniform framework. If we go into the next slide. I know the committee has spent a lot of time looking at the success of different multi-payer alignment models. I'll just share one that has stood out to the NCQA team under the state innovation model, which is New York's many years long effort to standardize the focus on primary care. As many of you may know, under this SIM model, New York State replaced several different primary care initiatives with a single unified framework, giving one consistent set of expectations, supports, and transformation standards across plans and practices. It aligned on a standard primary care core measure set. It aligned incentives across Medicaid and commercial plans. It leveraged the NCQA PCMH program at some point as well. And it was backed by statewide data exchange through Shiny. And importantly, the implementation allowed flexibility and regional variation because often things are a little bit different when you get closer to the community. Now, I know the CMS analysis around SIM models across the country showed mixed results on costs and outcomes, but models like this were successful in creating alignment and focus and harmonization. And it's possible that different levers are needed to be embedded into these programs, and a longer timeline is needed to truly see the impact on population cost and health. The main takeaway for me is that convening payers, getting to even partial alignment, and aligning with care delivery in important domains like primary care delivers real value and should be a big part of the solution. If we go into the next slide. So at the NCQA, we're focused on at least 3 areas to start where we think we can play a role and support this movement. The first is the transition to digital quality measurement. This is not just about using technology and data because it's available. It's about reducing burden, leveraging the data that is available with standardized mechanisms to enable clinically meaningful quality insights at the point of care and in near real time, and aligned across all the different levels of the system, because the way things are being computed would then be the same. This would radically reduce burden and enable much more real-time population health management. The second is measured cohesion and alignment. We are starting to talk about how do we evolve HEDIS to focus on populations that matter, bundles of measures that can be aligned on and harmonized across programs and partners, including the domains I mentioned before, across patient-reported outcomes, midpoints and endpoints around clinical outcomes, avoidable low-value care, and avoidable end events that no one wants to happen, like strokes and heart attacks and amputations and landing on dialysis. The third is to strengthen the backbone of primary care, behavioral health, and important domains of care. This would help us align across managed care and care delivery with uniform notions of quality and outcome success, and help us establish more data sharing, as well as more of a shared value framework that can address some of the gaps I mentioned earlier. So we see NCQA's role as a neutral and independent convener, leveraging evidence and best practices to align on what good looks like in quality definitions and measurement, and to work with all the policy stakeholders and constituents to achieve that goal. So thank you for the time today, and look forward to the Q&A.
Thank you so much. So next, we're excited to welcome Ms. Emily Transue, who's the Chief Clinical Officer at Imagine Health. Welcome, Emily.
Thanks you for having me. I'm going to speak a little bit to a Medicaid perspective today, among other things. Let's go on to the next slide. I'm the Chief Clinical Officer at Imagine Health. We are a national nonprofit healthcare consulting firm and contractor. We work collaboratively with patients, providers, payers, and other stakeholders, including a number of folks who you've heard from on the panel today and yesterday, to reimagine, redesign, and implement sustainable improvements in healthcare. We have a number of service lines, including care management, data solutions, quality improvement, and research and evaluation. Go on to the next slide. My background prior to coming to Comagine Health, I worked for a number of years as a medical director at the Washington State Healthcare Authority, which is the agency in Washington that oversees both Medicaid and public and school employee benefits. And I'll be speaking a lot to the work that we did there in my talk today. We convened the Washington Multi-Payer Collaborative, which created the Primary Care Transformation Initiative, and we'll be talking more about both of those. Prior to that, I have experience as a medical director at a managed care plan and also spent many years as a primary care internist at a physician-owned practice. So I come to this question of multi-payer efforts having sat at many seats around the table. Next slide. Starting in 2019, the Washington Healthcare Authority convened a group to develop a new primary care model, working with the state's payers and with the primary care provider community. We had both separate and shared meetings with payers and providers. All of the Medicaid MCOs in the state, as well as all of the state contracted commercial payers, were involved. We also included a broad variety of providers looking for diversity in size, location, rural versus urban mix, and payer mix. We invited a neutral convener, which was the folks from the Center for Evidence-Based Policy at Oregon Health and Sciences University. They helped us to maintain antitrust guardrails, among other things. And this work drew on prior multi-payer experiences that our CMO had had in Colorado and elsewhere. I think you've heard a lot already that each of these efforts builds on other efforts, and we were certainly doing that as well. Next slide. This resulted in two memorandums of understanding. The first in 2020 established the general principles of the collaborative, an agreement on the general structure and key components of the Primary Care Transformation Initiative, which we'll look at in a second. Each of the signatories committed to being part of the initiative and making good faith efforts to implement it. The MOU was renewed and updated in 2024, with signatories agreeing to ongoing active participation in the work and supporting its strategies. Signatories agreed to adhere to the alternative payment policies for primary care that the group developed, and also to using the Washington Primary Care Practice Recognition Program to inform their provider partnerships and contracting strategies. The next slide. This was kind of the background of the Primary Care Transformation Initiative. There were commitments from both payers and providers. Payers committed to aligning payment and incentives and to increasing financing in primary care measured as a percentage of spend. Providers committed to work to increasing capacity and access and to applying actionable analytics crossing clinical, financial, and social domains. That was all in support of really experiencing primary care as integrated whole person care, including behavioral health and preventative services, and having a shared understanding of care coordination and where providers fit in that continuum. The goal was for all of those things to result in aligned measurement of value out of the model, incorporating all of the triple aim outcome measures. This was kind of the general background we were working from. On to the next slide. I'm going to talk about a number of challenges and how we address these. All of these themes are familiar to you from the last couple of days, as well as your previous work: alignment, convening, trust, assumptions, incentives, risk adjustment, and some specific sticking points. Next page. So alignment is always kind of a bugaboo, I think. Everyone always agrees that alignment is critical, but I joke that many of us interpret that as all of you should align to whatever it is that I am doing. There's a reason for that, which is really that systems are already aligned to the many disparate forces that are influencing them. And anytime you try to impose alignment with a given program, you run a risk of pulling folks out of alignment with the other work that they're doing. So for example, if as a state you require all the payers to use a common data platform or portal, a national platform may lose the functionalities and the programs that they've built into their national platform. Similarly, for providers, if you agree as a state to work with a common quality measure set, your federally qualified health centers are still going to be accountable for the UDS and CHRQ measures, so you may not have reduced burden as much as you thought you were going to. I think bottom line, it's really important. It's really easy to be myopic about alignment within a given model, but it's really critical to be aware of the larger picture and consider the impacts that you're having in a holistic context. To the next slide. In Washington, around quality measures, we were helped by the existence of the Washington Common Measure Set, which is a statewide set for contracting that was legislatively mandated in 2014 to try to reduce burden around the many quality measures that are out there. This set is maintained by a multi-stakeholder group called the Performance Measures Coordinating Committee. And we were able to convene a subgroup of that to select primary measures for the primary care transformation initiative. That included both a primary set and then a secondary set for different populations. Of course, it's always challenging to consider different populations. Internists use very different measures than pediatricians, for example. The common measure set helped us in Washington. Clearly, at a national level, the increasing use of the CMS Universal Foundation measures has the potential to be a huge facilitator of multi-payer work. I think broadly, having a really commonly accepted and parsimonious measure set is very critical to enabling any multi-payer efforts. Next slide. Even when you are working on a state-based program, Medicare is still the elephant in the room. Medicare has such a high percentage of payer mix, particularly in rural areas. Medicare also enables consistency across states for national payers, and many Medicare models have a time horizon that is long enough to justify the investments that all participants make in participating in a multi-payer model. In Washington, we had really hoped that the Making Care primary model, which was closely aligned with the model that we were developing, would be able to drive our primary care efforts forward at a speed that wouldn't have otherwise been possible. Obviously, in practice, that didn't exactly work out. But I think that when that alignment with Medicare is possible, it's a tremendous, tremendous force at the Medicaid and state level as well. Next slide. We have heard often that change happens at the speed of trust. Discussion really needs to happen both within and between different groups in a model. We found that there was much more frankness in rooms where we had just providers or just payers. People were willing to say things that they weren't willing to talk about in a larger group and that really needed to be heard. And at the same time, it was also essential to have meetings together to really build trust and relationships, and also to enable addressing key conflict points. This is a map below of, in the first year of this work, how we convened primary care providers and payers separately and then together. We also really found that having a neutral convener was critical to supporting that trust building, as well as to navigating some of the hazards around antitrust issues and others. Next slide. There are a lot of unstated assumptions. And it's very easy to go happily along through a model and then suddenly realize that people are not talking about the same thing. So a few of those, looking at really is a model intended to increase the overall amount of money in a system, even a subset like primary care, or are you really talking about rearranging or redistributing or changing the timing of how dollars are being spent? Are providers expected to increase the number of patients that they're caring for? The idea of moving away from volume and into value means very different things often to payers and policymakers than it does to providers. Where does downside risk fit into the equation? I think we've seen some real changes in how this is perceived, particularly since the COVID epidemic. Which services and which providers are included in the model? It may seem very simple to say primary care and primary care services, but there's a lot of complexity in defining what is in and out of that, and that has huge impacts on the model. These are the kinds of things that you may not realize are critical assumptions and may forget to address, but really being explicit and clear about this is critical to having a successful model. Next slide. Incentives. Multi-payer efforts are time and resource intensive, and it can feel like there's a lot of risk to be engaging for both payers and providers. I think it's important to include both incentives and requirements. We found it was successful to require payers to come to the table and be part of the conversations. States have a number of different kinds of contract methodologies that they can use to lean on their payers, both on the Medicaid side and on the commercial side. We used a lot of those in different ways in our work. I think it can be really successful to incentivize early adoption and then think about penalties later on. So you're making it worth people's while to participate early, particularly providers, and then later use penalties to pull people in. Really, though, a model should be self-sustaining once it's in place. I think it makes sense to really push people to engage, but a successful model ought to be self-sustaining and rewarding to all players involved once it's being used. Slide. Social risk adjustment. Risk adjustment in general, of course, is critical to equity and to avoid penalizing providers who care for challenging populations. I think a special note, particularly in Medicaid, is that social risk adjustment is also really critical. That's true in Medicaid and also in other programs that address similar populations. So the exchange population, programs for undocumented persons, just won't work unless you have social risk adjustment. I don't think it's as important that that be standardized across payers necessarily, but the methodology or methodologies have to be credible to the provider community. Next slide. A number of sticking points will come up. You've heard about many of these. I've talked about some of them. Attribution methodology, data platforms and reporting, risk adjustment, quality measures, which services and providers are included and excluded. All of these can be standardized. Not all of them necessarily need to be. I think for efficiency's sake, it's essential to build on what you have. For Washington, that included the existence of the common measure set and pre-existing work that had been done around definitions for primary care. But differentiating what you're going to standardize and not, and really, really prioritizing what's essential versus what's just a nice to have as you move forward. Next slide. So a couple of lessons from our work to summarize. Alignment, try to think beyond the model that you're working on and look at a more global level of alignment. Always move at the speed of trust, otherwise you will think you're accomplishing things and then they will fall apart when it comes to a crunch point. Be very explicit in confirming your principles, assumptions, and goals. Convene payers and providers and policy folks both together and separately. Think about the use of both positive and negative incentives. Really lean into social risk adjustment, especially in the Medicaid population and similar populations. And when it comes to those sticking points, really try to build on what you already have in a system and then prioritize what's most important. That's it for my slides. I look forward to the discussion.
Thank you, Emily. Last but not least, we are happy to welcome Dr. Rushika Fernandopulle, who is the Chief Executive Officer at Liza Health. Please go ahead, Rushika.
Myself off mute here. It is wonderful to be here with everyone, and thank you for having me. If you go to the next slide, please. So I was going to give a bit of a provider perspective as leading a physician group, but we were not at all a typical physician group. So I'll give you a little bit of context. So I'm a primary care doctor, general internist. About 20-something years ago, I woke up and realized that the current primary care model was fundamentally broken. And I'd spent a lot of my career doing what everyone else did, which is what I call the incremental change model. Maybe we can just tweak a little bit, whether it was called total quality management or CQI or Six Sigma or whatever you want to call it, and sort of decided maybe the thing was rotten to the core and that we had built a system based on transactions, document code bill next, as opposed to based on relationships and actually improving health. So in a fit of craziness in 2004, when doctors didn't do this sort of thing, decided to quit the day job and start a practice, Renaissance Health, the rebirth of primary care. And we were going to build a new model from scratch. And I'll talk a little bit about that. We did that for several years. We realized that this sort of model, and this sort of model wasn't just better for patients, but was going to lower total healthcare cost. We ended up working with some employers, one of the first people to do so. We did a pilot with the Boeing company in Washington, thing called the IOCP, the Intensive Outpatient Care Program. And we were sort of led by a gentleman named Arnie Milstein that many of you may know. We then worked with the casino workers in Atlantic City. Atul Gawande wrote a nice article about us called The Hotspotters that allowed us, it was a cover story in the New Yorker in 2011 that allowed us to raise some capital. And I said, I want to try to do this at scale. So we created Iora Health in 2011 to try and build this model. We grew that over 10 years, and I'll talk a little bit more about that. We merged with a company called One Medical, and then we sold the combined thing to Amazon, as Lindsay mentioned, and we're now the basis of most of Amazon's care delivery model. So next slide, please. So I thought that if we want to change how we deliver care to people, right? And remember, the basis of Iora was starting from scratch, but what does a care model look like if we're going to do the right thing for patients? And realize you have to change 4 different things. We have to change the process of how we deliver care. Once you start completely changing the process, you realize you need a different IT platform. You can't do this on Epic or Cerner or Allscripts or Athena because they were not surprisingly built for the current model of care. That required sort of a different people and culture. And then probably the most importantly, you need to get paid correctly in order to make this work. So let me go through those in turn. So the next slide, please. So the model was very different. And a lot of things are now incredibly obvious. And lots of people are doing. Remember, we started doing this in 2004, and people thought we were out of our minds. We thought, again, the job to be done was not see one patient at a time and do the best job you can, bill as high as you can, move to the next one. But the job to be done was we had a population of people. They are our problem. How do we improve their health, keep them out of trouble, and do whatever it takes? And so, yes, we have doctors. Their job as doctors is to diagnose and prescribe. The hard part is not that, not telling. And what we do is we see people in a visit and we tell them what to do and we say, good luck, sucker, I'll see you. And we pick a random interval for them to come back, right? That's not very effective. So what we need is to wrap a team around people. So we had people we called health coaches. They're from the community, spoke the language of the people they served. Their job was to really accompany people, to channel Paul Farmer, who sadly passed away a couple, it was his death anniversary, to really hold their hand when it's the right thing to do, kick them in the behind when it's the right thing to do. We also started integrating behavioral health and social work. And all this stuff is fairly obvious now. Omni-channel care delivery, proactive and not just reactive, groups of people, provide transport if you need to, et cetera. So very different care model. Pretty much everyone on the call who's talked about this knows what this model is. It's not that we don't know what this is, by the way, we just have to do it. Next slide. And again, you can't do this. This care is not a little different than typical care. It's completely different. And you can't do it on Epic or Cerner or Allscripts, right? Because they're fancy billing platforms that were designed to help you charge more and gen up more 99214 and 99215 codes. If you don't care about that, you need a different one. So we created our own, we called it Chirp. It's a care collaboration platform, not really an EHR. It's more a CRM than an EMR, and really helped us do our job. Next. And this is key. Like, you cannot do this in a fee-for-service model. You cannot even kind of do it in a fee-for-service model. I think trying to innovate the care model without innovating the business model is a waste of time. I think that's why a lot of the medical home stuff was a waste of time, right? So we started to the right of this, of the line, where at the very least, we would take a primary care case rate. Our first practice in Arlington, we were one of the first direct primary care practices in the country, along with Garrison Bliss in Seattle and Chuck Kylo in Portland and a handful of us, where we simply asked our patients, at the time payers wouldn't give us a time of day, and we simply asked our patients, look, we're going to try and do something very different. Last I checked, your payer's too stupid to pay us the right way. So last I checked, I took an oath to serve you and not them. So here's the deal. If everyone paid us about $40 a month, we'll break even. If you're rich, pay us more. If you're poor, pay us less. We then evolved where people would do that, and we went to the payers, and when we did our first Boeing pilot, Boeing would give us a fixed case rate. Occasionally they had some bonuses on it or some shared savings, and eventually when we moved into the Medicare space, we started doing full risk and taking full 100% up and downside risk. The dirty little secret is that primary care, as I think has been mentioned on this by other panelists, are typically 5 to 6% of total healthcare spend, and that's completely under investing in it. And we ended up, spending 10 to 15% on primary care. And what you do, of course, is you then keep people out of the hospital and out of the ER, and the total costs go down. So next slide, please. So we grew this to 49 practices in 8 different markets. And you see the map here. We partnered with a number of folks, including Humana, United, CVS, Aetna. We also ended up working with CMS directly to create a model, which was initially called direct contracting, that morphed into ACO REACH, which is soon to morph into LEAD, which allowed us to do this sort of care for directly with original Medicare patients, works on Blue Cross plans, and also some employers like Boeing and Dartmouth, as I mentioned. If you go to the next slide. I was very proud in 2022, the first complete year of CMI direct contracting. We were the top in the country of performance, 22.3% net savings rate, 22.3% net savings rate, right? Imagine how transformational that would be for the country if we could lower Medicare costs by 22%. By the way, I think there's a problem with CMMI demos where what we do is we do a demo, we get a lot of people in, and what we do is we judge the demo by how the average does. And there are a lot of jokers who come into these things who don't know what they're doing, and instead of judging by the average, and a lot of good demos have been thrown out, we should look at the people who actually perform well and say, we should keep you and kick out the people who don't do well, and then move forward with the people who actually know how to perform. So in any case, these models work, right? And I think we all know that by now. Next slide. If you ask, like, why is it that we perform well? If you look at almost all the people at the top of that chart for CMI direct contracting, is we didn't do what the vast majority of practices did, which is the classic foot on the canoe and the foot on the dock, and tried to run a practice where we're doing optimizing fee for service and optimizing value-based care in the same place. That is a fool's errand. It does not work. It's not a little different. It's completely different. So we just simply made a decision. Again, I'm a doctor. I took notes to serve my patients. I cannot serve them in a fee-for-service model, so we're going to stop doing it. And so our attitude was we're going to be fully in on value-based care. So all of our patients were in a value-based care model, right? I think that is the biggest thing from multi-payer alignment, is getting everyone to the value-based care. By the way, I think a mistake the industry has made is saying we're going to move slowly to this new world. I think that's probably the hardest thing, because you're then stuck with the foot in the boat of the canoe. You really have to move there quickly. That's the only viable model. So next slide. So even given we were only doing this, we started our life with single payer practices. So we started at Dartmouth in Hanover, New Hampshire with Dartmouth Health Connect. It was a practice that was solely serving Dartmouth College employees. And then over time, what we did is that we thought of it like building a shopping mall. We'd get an anchor tenant like a Nordstrom's, and then we'd add lots of little other people around them. And so we had Dartmouth in there, and then eventually we added other employers like King Arthur Flour, United Healthcare gave us a Medicare contract for people. Similarly, in Phoenix, we worked with Humana. We were single payer with Humana for several years, and then we branched out and started seeing people from Devoted, some Boeing commercial patients who are sicker and older, and then did direct contracting within the site. So again, we moved to multi-payer in all of our sites because that was a way that we could actually serve multiple populations. Let's go to the next slide. So we are not typical, right? The way we got alignment between multiple payers is we simply insisted on it. And there are a few features of that. So one, which I think is really important, is that our relationship with our payers was one of a long-term trusted partner, not a vendor. We tried very hard not to go through the consultants who would try to bid people every couple of years, treat you like a vendor. No, we are long-term partners. It's funny. Boeing once pointed out, we buy tires for our 787s. What we don't do is say any schmuck who makes tires just come slap them on our plane. Of course they don't. We're going to find a few people who do this well, going to work as partners with them over the long term, and we're going to build better planes that way. And we're going to do. And by the way, one of our biggest suppliers is our healthcare. So why don't we do that with you too? So long-term agreements are very key. Our first agreements, like with 3-year agreements. At Dartmouth, we moved to a 5-year agreement. And then when we did our Humana contract, they were 10-year agreements. 10 years makes a complete difference. And then the seller of the services, IORA, would determine how we get paid. And the buyers either agree or they don't. It's funny, in every other industry in the world, the people who deliver the service decide how they want to get paid. If I will open a restaurant and say, this is how I want to get paid, if you don't like it, don't come here, right? And so the goal is just say no, right? And eventually people come around. Simplifying the arrangements are really, really important, right? We have gotten way too complex in these sort of models. And and again, I think in these long-term partnerships, you can actually do that and simplify and then streamline reporting. My favorite payment model is what Jim Kim at Dartmouth and we did. We decided to build this practice for Dartmouth employees. He said, "How do you need to get paid?" And I said, "Look," and he was self-insured, right? So he could do whatever he wanted. And I said, "Look, we need really to do this simply. So here's the deal. How much do you pay for primary care right now?" And the answer was roughly $40 per person per month. Of course, they paid it per visit and with all the ancillaries, but that's what it turned out to be. I said, great, let's double down on primary care. I want $80 per person per month. My billing was a one-line email once a month. We have 1,800 patients times 80, send me a check. It meant, by the way, that we could ask the question, not is there a billing code for this, but will it help the patient? Now, trust but verify, right? Of course, what we said to Dartmouth is you need to believe that this sort of intensive primary care, value-based care, is going to save you money. So every 5 years, we will get an independent academic to do an evaluation of the praxis. We'll do a case control using RTI methodology, propensity matching, take the people in the practice, match us to a group of people that chose not to join the practice, do a trend over trend analysis. And as long as we're saving you money on total healthcare costs, including the extra primary care you're paying us, we keep going. If not, you should fire us. And actually, you shouldn't fire us because I'll quit because we're wasting our time here. And so that was it. And we've been doing this for 15 years now up there, and it continues to work. And then the key is to be willing to adjust both ways. We had places where the rate we picked was too low, and we were transparent about economics, again, as a long-term trusted partner, and we adjusted it up. There are places we were getting paid too much. We worked with the Freelancers Union in New York, and we're getting paid too much, and we adjusted down the rate, right? And that's the way you work as partners. So last slide, please. So a few thoughts on multi-payer alignment for value-based care. So it is absolutely necessary to transform practices. Again, you cannot practice different ways for different payers. We've tried that before with color coding charts. It's a nightmare. It's morally and practically untenable. So you've got to do it one right way, and that leads to better outcomes. The biggest barrier today, by the way, I think is getting the commercial payers on board. Who would have thought that Medicare would be leading the way and Medicaid behind them? The commercial payers, despite the rhetoric, have tiny amounts of real value-based care, and then that needs to, and they need to do it for both fully insured and ASO lives. Would happy to talk about that. We need to sync on the model of payment. That's the first thing, that's fee-for-service versus capitation. But then also, as everyone else mentioned, getting risk adjustment quality frameworks, reporting aligned is also important. But the biggest one is really aligning around, we are going to align our practices around treating people in this value-based way. And then again, likely we'll need some government push and allowance for this to not fall afoul of antitrust rules. So I will stop here and looking forward to the questions. Thank you.
Thank you, Rushika. All right, thanks to all of the experts for those wonderful presentations. I'm sure there's going to be some questions to follow. So we're going to move into the discussion portion of this session. So at this time, for all the PTAC members, please raise your hand in Zoom if you have questions for our guests. Additionally, we want to encourage our experts to ask follow-up questions of each other. You can signal that you have a question by raising your hand in Zoom. In the interest of ensuring balance across different perspectives, we encourage you to keep your response to a few minutes. All right. With that, I see Krishna first in line here.
Thanks, Lindsay. Yeah, excellent job, team. It's great to hear your perspective, just these lived experiences and insights as well. Fantastic. Most of you, I think, thematically mentioned the sort of data that is trusted, data that's actionable, and obviously, Rushika, you mentioned this like platform you had to create because the core EMR systems didn't work as well. It's a topic close to my heart, given the maybe a decade I've spent trying to like make it better as well. And much like care delivery, I feel like the data landscape is also fragmented. There's EHRs and portals and data files, and there's a lot of like variability there as well in our just healthcare landscape. Curious on any recommendations based on your work on just how do we reduce the fragmentation? What does the path forward look like? I would love just some recommendation insights, particularly as we do this sort of nationwide. So.
I have a few thoughts on that, Krishna, and thank you for the question. You are right, and particularly when you're working with the whole point of doing, I think this is centered a lot around primary care, and I think everyone who's tried to do real value-based care realizes that we have to rebuild the system, not top down, but bottom up, right? Start with the consumer and then move upward. I think that's why, these initial ACOs sort of failed, to be quite honest, because we started with the hospital and tried to trickle down. We had to start primary care up. But now if you're using, and primary care has to be a lever, if all you do is change primary care, who cares? Primary care has to be a lever to then rationalize the whole rest of the system. But if we want to do that, we have to get the data from all these other places, right? And that's where the problem comes. And despite what the laws say, we and everyone else who's tried to do this run into all sorts of information blocking that goes on, right? Because both the EHR companies and the health systems and the health plans think that they own the data. I think we have made a strong statement that no, the data actually belongs to the patient. That is the right thing. By the way, many countries who do this better than us, they don't even keep records at the provider or the plan level. The patients, I was in Thailand in Singapore province, and everyone has a little book that they keep with them in a very guarded place at home. When you go to the doctor, you bring the book in, the doctor looks in the book, he looks at the labs. If he adds a lab, he writes it in, changes the med list, and hands the book back to you. One source of truth belonging to the patient. That's better than we have, right? With the billions and billions of dollars we're spending. So I think we're now finally getting there. There have been lots of problems with trying to build PHRs. As you know, Google and Microsoft and a bunch of people tried this. They weren't very trusted. They probably shouldn't be. But I think now, and particularly with AI and with some of the 21st Century Cures Act, ONC final rule, and using the TEFCA rails, it's finally starting to happen. That's part of what we're working with on Liza Health, because I do agree with you. We have to fix that.
Yeah, I would just add from the NCQA perspective, the organization spent a lot of time on the digitization of quality measurement, as I mentioned briefly. And I've been taught by the team by the massive levels of data fragmentation, as Rushika said, that exist. And it ultimately comes down to where should the data be tracked and who should it follow? And my guess is we should all say it's available longitudinally to patients and their families and caregivers. That is not how the data ecosystem is organized. Krishna, I'm sure you know that better than many. there are massive issues around data quality. That's one area that NCQA is going to be spending more time. But I think if you just take a step back and say, will we get to the kind of universal quality and outcome signals that really matter based on claims data? No. I think we would posit that you wouldn't. There are many richer things that should guide care and population health management that require interoperable clinical data. And then you get to this data fragmentation issue, and then you start to drill in and say, what is this? Are we really using standardized data models and data exchange mechanisms like FHIR? And many organizations are at much earlier stages of that journey. So we are hearing regularly from plans, analytics partners, health systems about the amount of investment and time and change it would take for them to set up their data in the way that would be required in the future. I think that's something else that needs to be considered, which is not every organization has the scale, the sophistication, or the resources to go on that journey.
Thank you.
Just one thing I would add to that, another piece of this question is social data, because I think to do this work, we also really need to be exchanging social data and involving CBOs and others in it. And so as we think about building better data systems, let's not forget about that part, because really for this to work, we need that too.
Great point. Thank you all.
All right, Larry.
Great session this morning. I actually have 3 questions, one for each of the speakers, but anybody else can join in. But Vivek, my first question for you is, I've been in the leadership of the American Gastroenterological Association for decades, and we are always developing measures and metrics and trying to get them into approval by NCQA so that they can then be incorporated into EHRs and so that we can actually use them clinically. But the time factor takes so long. Are you working on anything to make this more nimble? Because frankly, it takes years to get a measure approved through the process and then implemented. And we cannot move at that speed. We have to move faster than that.
Yeah, it's a great point. I'm starting to learn about that challenge. I think our own team would say they want to be able to accelerate the process while maintaining the integrity. And maintaining the integrity means the scientific integrity, the feasibility testing. Ultimately, there are going to be ways to enhance that process. But we're also not the only party. As you know well, it's a multi-stakeholder approach. There's a consensus-based process through CMS that Patel coordinates. So we're all participants in different levels of the process and structure, but we are going to be looking at how can we accelerate our part of the equation while maintaining the scientific and feasibility integrity so that ultimately the measures that get developed and aligned on can be produced in an accurate and insightful way. So no clear answer yet, but yes, that will be an.
We're gonna hold you to that. That's gonna be one of your endeavors.
And on the flip side would be we have to work across the quality development measure development ecosystem, including medical professional societies, to say how do we create those universal signals together and where do we adopt best practice frameworks from each party and use them mutually.
Well, that's a great statement to help me with my second question, because one of my other endeavors at the AGA has been to convene multiple payers across the country to try to come up with common processes around guideline development, around correct coding initiatives, and around value-based care. But I'm going to address this to Ben and Emily. And putting multiple commercial payers, you guys make, Emily, I think you made the statement that, we need to convene the payers. Well, when we convene the commercial payers in one room, they'll talk about coding, they'll talk about guidelines with each other in the room. But when it comes to value-based care, they quiet up. They get very proprietary about their financial arrangements. So PIPs? How do you get them to open up and work together in the same sandbox instead of trying to one up each other?
Such a great question. Go ahead.
Go ahead. Go ahead. I'll follow up.
I think absolutely, it's a challenge. I think one piece is really trying to be deliberate. Plans, and I've been on the plan side, so there's a tendency to say like everything is special sauce, right? It's all special sauce. We don't want to talk about it, but there really are only pieces that are differentiators, and so I think to the extent that you can probe, okay, can we talk about this, like the structure of the program is not likely to be a special proprietary thing. Really defining out what's proprietary, what people see as something that differentiates them versus not. There will be things that are non-starters, figuring out how people are selecting their patients for case management is not likely to be something that people will talk about, but there are other things that I think you can agree on. So I would say my general answer is bring people together in a room and then be explicit about what you want to talk about and let them be explicit about what they consider to be proprietary, and then sort of move forward from the pieces that you can find in common. And in my experience, people tend to open up a little bit.
Yeah, no, Emily, very much appreciated your sentiments, and Larry, I think it was a great question. I can step back and say in a previous role, had worked for an organization that had value-based contracts across a number of payers, and so very familiar with on navigating that environment. What I would say is this: first of all, we should always have the patient at the center of everything that we do, and to the extent that there is clarity on what are the best health outcomes, what are the right measures, like how should we be thinking about managing patients with heart failure and goal-directed therapy? How should we be screening patients for CKD? How should we be ensuring that older adults are getting high-value tailored care? None of that is mysterious, and so I think that there's probably actually more overlap than there is differentiation from one payer to another. That being said, I think that there's a couple of things that we can do to probably be more effective collaborators. One, we talked a little bit about the alignment of quality metrics and data collection, both across ACO models and Medicare Advantage. I think that will create just a much more streamlined environment so that the conversations on quality, will be similar. I think investing in data interoperability, whether it's through HIEs, whether it's making sure everyone's using FHIR standards. Again, I think those create the chassis that allows it to be much easier for providers to practice high quality medicine and have reasonable conversations with providers. I think a challenge has also been longitudinal care. It's impossible to have a fragmented system where a third of your population churns every single year. And so thinking through how do we create longer longitudinal relationships. Quite honestly, there are a number of practices that are probably suboptimal that benefit from patient churn, right? Whether it's deceptive marketing, and so just making sure that we create longer term runways so that people can make investments, right? If you think about it, if you're a GI and you're doing colonoscopies, there may be a decade before that member actually benefits from that screening. But we need to create situations where everyone benefits from that activity similarly. So, Larry, I hope that sort of gave you some sense of how we're thinking about this and where we think there are, opportunities, potentially to collaborate differently across, different payers and do it in a way that really benefits members.
Thank you. Thank you. Rushika, I did not forget you. I saved a question for you, but you're free to comment on anything else I asked. But I'm really impressed with what you've done. This is phenomenal that you had the vision when you had it to build what you did and how you approached it. I was hanging on everything you wrote, and I have a ton of comments. And one of the things the PTAC board knows I do is I grab quotes, and I'm going to use yours. Innovating the care model without innovating the business model is a waste of time. I love that. We've talked about that at PTAC. But my question is this: how did you deal with your specialists? How did you bring value-based reimbursement to your specialists when you're at full risk? What was your strategy?
No, it's a great question, Larry. And I think, as I said, if all you do is innovate primary care, you're wasting your time, right? It's 5% of healthcare spend. Who cares? It's got to be the lever, which then allows you to rationalize the rest of it. And by the way, this whole, we'll let the consumers do this navigation themselves, give them skin in the game and good luck, sucker. Like that's a fool's errand too, right? There's such asymmetries of information and asymmetries of power, thinking a consumer can do it. But as a primary care doctor, we can actually do that as their partner. By the way, that makes it really important that we are 100% aligned with the consumer. I think there are too many models where the primary care doctor is actually not working for the patient. They're working for someone else, i.e. the health system or the health plan, et cetera. That's problematic, right? For a lot of reasons. By the way, we would never allow that in financial services. We would call it a conflict of interest, a violation of fiduciary duty, but somehow we allow it to go on in healthcare, right? So put that aside. So how did we do this, right? So we started by saying it's our job to help people navigate the whole system. And so we started by building what we call good folks list. So we partnered with our health plan. We got as much performance data as we could. You remember, we knew it's a long time ago. The data wasn't that great, but we did as good as we could. And we identified the people we thought were good guys, right? And you can imagine all the things you could look for in the data to do that. And then we go meet with them. And we say, look, so for instance, gastroenterology, it's like, look, here's the deal. We want to look for one GI group that we can work with. And here's what we're looking for. Are you willing to work with us? And let's re-engineer the interface. So, when I'm setting for a colonoscopy, I don't need them to meet with you before the colonoscopy. You don't want to waste your time doing that. Tell me what prep you want. I'll do all of that. And then, by the way, if it's a normal exam, you don't need to come back to see you. I can tell them that, and I can tell you what the follow-up is, right? So we can re-engineer all of those things. By the way, what we found that's interesting is what's more important than finding good folks lists is actually finding the bad folks list, like Santa Claus, because there are a handful of specialists in each thing that are just doing egregious things. And we need to make sure our patients never go to those people. So you start with the bad folks list, you then go to the good folks list and you engineer it. We then eventually started putting some people on retainers. So what if we put you on a little bit of a retainer so that we can actually round together and talk about patients and people actually really like that. We do it over dinner. We would do a lot of curbside consulting and the like, right? And eventually in some markets, when we got to critical mass, like in Phoenix, we had 12 practices. We had 20% of all the Humana lives at one point. We did then even start hiring some of our own specialists to work with us. So that's, we have to explicitly do this, build this what we're building, by the way, is a bottom-up ACO, not a top-down ACO, right? But that's what we all have to get to.
I love that. Thank you.
Yeah, I just want to quickly add to that, really there's a significant gap, I think, in the relationship between payers and providers, and creating the right trust is so important. I love the thought that, I think Tom Lee said, the way that you get trust is that you give trust. And so just thinking through how we can change that dynamic. And so I'll give you, since you're a gastroenterologist, helping us understand what are the things that we should be thinking about. So, I don't have access to adenoma detection rates. When I have someone getting a screening colonoscopy, what I really want to know is how good a job is that GI doing at taking their time and finding adenomas, which is the entire purpose. And so figuring out how we can get that type of data so that we can reward those providers who are taking the time, who are thorough, who are getting the best outcomes. And that's part of a bi-directional. We've got work to do on the payer side, and we need to create those bridges, because I think that's really what's going to, when there is that disconnect, I promise you the patients feel
it. And I just want to quickly add to what Ben said. In the absence of that kind of alignment around what real clinical outcomes and excellence look like, and the data sharing to enable it, people are using claims and mostly looking at cost and their contracting arrangements. Yeah. And that does not add up to the kind of population health improvement that everybody's individually mostly oriented around in their own practice, or the patients want from all of us.
We
Thank
all
you,
need to add
everybody.
on to that.
I've used up enough of everybody's time.
But just one more sec. I mean, just to call out, I think that was a great answer. And also, it only works when you're an independent primary care group and there are independent specialists to contract with that you can pick and choose, which is not the way of the world in general. So it's a huge challenge.
Great point. Thank you.
Great point. Lauren.
Excellent presentations. Really excited to hear all your diverse perspectives. So I've spent many years really focused on complex populations, definitely designing models in urban environments. But I'm really curious to hear from each of you. Emily, you mentioned social risk adjustment. I'm interested in what kind of unique adaptations, approaches, or supports have you needed to design in for rural environments? I've been involved in frontier environments, Alaska, the border with Mexico, many rural communities need that support to be successful in this. So I'm curious how each of you address that and what considerations you may want to share for us to consider as we look at this topic.
Oh, that's such a great question and hard to tie a quick bow around. I mean, I think there are so many fundamental principles around what's happening in a rural setting that are just radically different from what's happening in an urban setting, all the way from, you know, it's nice to talk about, let's find the best gastroenterologist that that is going to have the highest rates that you can access. But if the only one in a 500-mile radius is, you know, that lady over there, you're going to see that lady over there. I think a lot of the contracting mechanisms kind of break down because, again, you can't pick and choose if there are not hospitals and others to pick and choose between. So, and then there's trying to understand what cost looks like in a setting that is so different. So many of our mechanisms to control costs kind of hinge on being able to see people in a certain time frame, being able to send someone home from the hospital and have them follow up the next day, you know, all sorts of things that just aren't possible across that kind of distance. And then there's the additional challenge that so many rural providers are really kind of catastrophically financially struggling. And so you don't have the ability to put the kind of pressure on a system that you would have often in an urban environment. So I think a lot of that is about realizing that, especially as you get into those more frontier kind of environments, you're going to have to loosen the rules. You're going to have to have an upfront system that is kind of more generous in how it approaches and assesses impacts. You're going to be really thinking about impacts that are more along the lines of, are we maintaining access? Are we keeping providers in the area that are there and need to be there, rather than sort of the winnowing down to the most productive few that a lot of models rely on. And again, adapting financial models to recognize the realities of systems in which not every level of care is available, and not every kind of follow-up is available.
So Lauren, I'll just say a couple words. So maybe inherent in your question is that healthcare is local, and we have to be careful when we build these things, you know, to get alignment is not trying to align across everywhere, because healthcare is different. The New York Times wrote a great front page business story on us many years ago. It called it the Starbucks of healthcare. Despite my quote saying this is not like Starbucks, right? You have a Starbucks in one community, they look exactly like one in another. But in healthcare, we have to build for the community, right? The expectations are different, the disease burden is different, the provider landscape is different, the logistics are different, right? So there are some things which we have to do the same because it's the right thing to do, but many things that have to adapt. And we just have to be careful not to over specify the alignment. You know, we know what to do in a lot of these things. So telemedicine obviously is the right thing to do, home visit teams, you know, helping people with transport and the like. You know, one of our biggest struggles when we, you know, Hanover, New Hampshire is sort of rural, is it's much easier to attract physicians to work in New York or San Francisco or Boston or Phoenix than it is in, Alaska or in Mississippi, et cetera, right? So I think that's part of what the struggle is. We would try to create these sort of fellowship programs where we would sort of get people to be willing to go places, and then, in a couple of years, you can come and work in Seattle or wherever. But and by the way, most other countries do things like that. And I think we have to solve the provider shortage issue in these places.
I would just add one thing that NCQA has done is to create managed care and care delivery programming around looking at disparities. And I think part of the impact of what you're flagging, Lauren, are disparities in health and care that exist for the reasons Emily and Rushika were describing. And so we have a program called Health Outcomes Quality Accreditation that really a lot of state Medicaid agencies are asking their managed Medicaid MCOs to adopt, which creates a baseline foundation of data to stratify populations by race, ethnicity, disability, other factors, and ultimately say, what are your improvement plans based on the gaps you identify once you stratify that data, leveraging obviously best-in-class standards that have been developed nationally. And then the other partner to that is a community-focused care program to highlight organizations that are adopting robust social needs screening and interventions. And you can imagine the two working hand in hand. And those things themselves won't solve the problem, but they will hopefully create a more consistent foundation for the partners who adopt them to say, what are we doing? What are the gaps that emerge, whether it's because we're in a rural area or there's specific community dynamics based on the people who are there, based on their experiences and level of health need, and are we closing some of those gaps?
I mean, the only thing I would also add, building on that, is just, considering making the telehealth provisions permanent, given, the fact that we want providers who are at risk to be able to meet patients where they are. And that's going to be an increasingly diverse, population over time.
Thank you all.
All right, we're approaching our last 5 minutes for discussion here. I'll add a quick one unless there's, okay, Lee's stepping in. Go ahead, Lee.
Such a great conversation. I was struck, I think, Rushika, you said that the slow, steady development along the HCP land continuum is a fool's errand because it just prolongs the time you spend with a foot on the dock and a foot in the canoe. Boy, have I lived that, both on the provider and the payer perspective. And so I love the group's thoughts about, HCP land laid out this wonderful landscape that seems like it's a developmental landscape, but it's in certain early stages, like the provider has to go through maybe a pay for performance, because that's when you learn that your data is or is not hooked up and your EHR code sets are or are not updated to be received and meet NCQA requirements and HEDIS review, all that stuff, right? That may be an important and necessary developmental step, but I just love your thoughts on what you see has worked contracting and what elements you pull out of different parts of value-based care, and when is the right critical mass to make a jump to full primary care capitation or some other model. So just how do you see that developing compared to how much of the market is trying to do it now?
So when we did our first Humana contracts, we created explicitly what we called road to risk models. So what we said was, look, we're just starting out, and we did this every market we go into. So we would say it's going to take us a while to build these systems because we don't have them already, right? And to get as you said, get this stuff working. So we had roughly 3-year road to risk models. Year 1, we are just at a primary care cap. Right, so we're not at any up or downside risk, and just pay us a primary care cap, and this is our sort of get the systems ready. Year 2, we would go to 25% upside and no downside. Year 3, we'd go to sort of 50% up and downside. By year 4, now we're running at full risk, right? So I think that was really important for us to sort of 2 things. One is to have that clear road and an expectation of when this will happen so you can build for it. The problem today is that it's uncertain, right? If you knew in 3 years we have to get here, then you can do, and it takes time. It doesn't happen when you snap your fingers, but to put those sort of explicit pathways in place, I think was very helpful.
I would say the pathway also, I like that description. I think there's a distinction between sort of what a carrier is offering and what a provider is choosing. So I think the provider has to move that way, but a carrier doesn't have to say like everybody's got to start early if they already know how to do it. So I think having the opportunity to offer to meet providers where they are in terms of those capabilities is really important. Another thing that I would say, all of those models that you just described were capitation. So it was the fee-for-service part of it you kind of had out from the beginning and then added the risk. And I think that's a really good model. There's still some challenges. We had a famous example in Washington that resulted in a big lawsuit between an MCO and a direct primary care provider in terms of, are you capitating? Essentially the root of that was they were capitating a whole bunch of people and the provider was only seeing about 5% of them, or maybe it was 10%. So figuring out exactly even what capitation means is important, but I agree that you can fix capitation earlier than risk and be safer.
Let me just add one thought, and I'm a deep believer in value-based care, but value-based care in and of itself is not necessarily a moral good. The outcome that we really care about is our patients getting better care, and value-based care is a powerful tool that we can use to align people and to get them that outcome. As I think through it, just going back on that comment I made about the relationship between payers and providers, trust is so important. And I think we need to get out of this mindset that it's a zero-sum game. And what we should be doing is arm wrestling over the percentage of premium, but figure out what are the unique capabilities that we as payers have and that providers have, and how we can partner together to get those better outcomes, which is what I think really matters. And I'll be honest, right? When I was on the provider side, even when we had millions of members at risk, we didn't have the sophistication, the data to really create the predictive analytics, the high value networks that we needed. And so I think the ability to go and say, how do we set one another up for success, with the idea being that when we have a JOC in a year from now, or in 2 years from now, 3 years from now, we are all going to be delighted with that outcome. And Rushika, I love the example that you gave about whether it was the freelancers union or another, where as part of the reconciliation, it showed that the dollars weren't where people predicted. And so you made adjustments. When you create a real relationship with people, you're able to do that and do it longitudinally and effectively. And I think that mindset and that partnership is actually really what the key is to create those successful outcomes.
Thank you. All right, we're in our final few minutes here. If there's any rapid fire comments from our presenters or things that haven't been said in your final moments, this is it.
So I just want to thank the PTAC for taking on this issue. This is a huge issue. And like I said, I would push you to focus on the commercial insurers. I think we've already gotten a lot of alignment around Medicare, and Medicare's leading the way, but until we get the commercial insurers on board, it's going to be very hard for the vast majority of practices to actually transform.
Thank you. All right, well, I think at this time I'll go ahead and thank all of our experts here for joining us to kick off day 2 with some great conversation and for sharing your insights. You're welcome to stay and listen to as much of the meeting as you can. But at this time, we are going to have a break until 10:50 Eastern Time. Please join us then as we welcome any public stakeholders to share comments, and then our day will conclude with a final committee discussion.
Produced by the U.S. Department of Health and Human Services.